I will be talking to you on the clinical features of INOCA and MINOCA. And as we have already seen, we have patients coming in with myocardial infarction and normal coronary arteries, and that we label as MINOCA. And of course, is patients who come in with ischemic heart disease and normal coronary arteries as INOCA. The normal appearing coronary arteries, strictly speaking, especially for the postgraduates, it's luminal stenosis less than 30%, and non-obstructive CAD is lesions more than 30% but less than 50%. Now there's so much of talk about INOCA, and why is there an apparent increase in the prevalence of INOCA is probably because of earlier detection of ischemic heart disease, because of better diagnostic techniques, and more frequent use of advanced instruments like IVS and OCT, and improved primary prevention strategies like more use of statins and ecosprin and antiplatelets when needed, and further an increased risk of obesity and diabetes because of sedentary lifestyles may also contribute to an increasing prevalence of microvascular dysfunction or spasm in patients even before the atherosclerotic burden increases. Now, what are the limitations? Before we label a patient as INOCA or MINOCA, we should also know about the limitations of conventional coronary angiography. Conventional CAG cannot detect vessels, disease in vessels less than 0.2 millimeter. It does not directly assess the vascular function. Thrombogenic plaques need not be obstructive, and obstructive plaques need not be thrombogenic. The total number of coronary segments involved is more important than the severity of the stenosis. The diameter of the stenosis in a regular angiogram is compared to the diameter of an adjacent vessel, which is thought to be normal but may not be actually normal. And lesions are sometimes underestimated because of a positive remodeling of the vessels. Now, lots of studies have been done on INOCA and MINOCA. The pioneering studies of Shiva Bhaskari Pasupati and several others, as listed here. So when you get a patient with ischemia or myocardial infarction coming in, the first step in the assessment is to exclude non-ischemic causes of an elevated troponin level like pulmonary embolism, myocarditis, cardiomyopathy, chronic kidney disease, sepsis, etc. Most of these conditions are readily identifiable by clinical scenario, except for myocarditis, which can masquerade as acute myocardial infarction, but can be delineated by CMRI. Myocarditis is a cause of almost 7% of patients diagnosed as MINOCA, and cardiac magnetic resonance imaging can differentiate the two. Injury to the subendocardial region that extends transmurally suggests an ischemic cause. Injury localized to one or more of the coronary territories also suggests an ischemic cause. Once you feel the patient is probably having INOCA, the first thing is to rule out lesions in the coronary arteries that could have been missed out by the coronary angiogram. Therefore, here you get the advanced imaging techniques like IVS and OCT, which can pick up missed dissections, plaque ruptures, erosions, etc. The prospective study said that mild lesions in the angio that were missed and which later became culprit lesions were picked up by these techniques at baseline itself. So second is you have to rule out inherited and acquired thrombophilias, protein S, protein C, factor Leiden, etc. Maybe they could have caused an occlusion of the coronary arteries leading to an MI, and later on these clots could have got lysed. Takotsubo cardiomyopathy is another subtype of MINOCA with the characteristic wall motion abnormalities, which INOCA and MINOCA refers to ischemia and MI, so occurring with normal or near normal coronary arteries, and 50% of patients with IHD, irrespective of whether it's acute or chronic stable angina, can have INOCA. 5 to 15% may also develop MINOCA. And intermediate risk for the importance of INOCA is that it has an intermediate risk for MACE, elevated rates of readmission, repeated angiography, poor quality of life, and reduced functional capacity. At 10 years, cardiovascular death or MI occurred in 6.7% of those with absolutely normal coronary arteries and in 12.8% of patients with non-obstructive disease. And as far as the age and sex goes, females, INOCA is more common in females, especially younger people. There is no special cardiovascular risk factor which is more common in INOCA except for hypertension. Smokers can have an increased incidence of vasospasm. It's also associated with high incidence of peripheral vascular disease, cerebrovascular disease, liver disease, renal disease, and malignancy, often associated with increased carotid intimomedial thickness and cerebral IMT. Symptoms are no different from obstructive CAD, except that if you have vasospasm, you can have episodes which are precipitated and which are transient. There's a higher prevalence of NSTEMI compared to STEMI. The troponin elevations are smaller. Transient ECG changes can occur if it's a vasospastic angina. And in the echocardiography, you can and need not have wall motion abnormalities. INOCA has set off the recognition of disorders of microcirculation, and the core-MICA study has shown that invasive CAG would therefore be considered incomplete without the assessment of coronary vascular function, which the next person will talk about. And the causes of INOCA, the previous speaker has also already said, epicardial and microvascular vasospasm, microvascular angina, coronary slow flow, cardiac syndrome X. Now that the term is no longer used because the European Society of Cardiology says that INOCA is a better term. And this is a patient who had a PTCA and then developed a spasm. And you can see the second slide which shows that the spasm has been relieved. This is a patient with infarction and then he had coronary slow flow. INOCA and MINOCA can be investigated by non-invasive and invasive procedures. I won't go into the details. And ESC recommends assessment of vascular function in patients who had ischemia and who have no stenosis in the coronary arteries, and also transthoracic Doppler can be used in these patients. Few opine that a trial with vasomotor specific anti-anginals could give the diagnosis and reduce the cost of diagnostic guide wires, adenosine, acetylcholine, and the risks associated with these. So that is why non-invasively it can be assessed by Doppler, but assessment of coronary flow by Doppler is sometimes very difficult. This is a study done by me where out of a total of 1,214 angiograms done, 96, that is 8% had coronary slow flow. These patients, I did not include any patients with obstructive CAD, and I found that slow flow in all three vessels was more common. If it's going to be a single vessel slow flow, it was more of RCA and LAD. There was no big difference in comorbidity. However, the commonest risk factors was hypertension and diabetes and smoking in 8%. But I found the left ventricular global longitudinal strain was reduced in 69%, mostly in patients with LAD slow flow, double vessel and triple vessel slow flow. And the RV-GLS was normal in 83% and abnormal in 70%, mostly with RCA or LCX slow flow, indicating that definitely microvascular dysfunction is affecting the myocardial function because of an impairment of coronary circulation, even if it is at the microvascular level. And the treatment strategies, first you have to treat the patients because there is an increased incidence of MACE and to improve the quality of life. Initially, you have to exclude non-cardiac causes of troponin elevation or altered ECG changes. And what are the treatment targets? Reduce the risk of MACE, risk factor management, avoid precipitating factors, anti-ischemic treatment, and anti-nociceptive treatment. And what is next? You can have pharmacological therapy with ACE inhibitors, ARBs, beta blockers, emerging therapy with ticagrelor, endothelial receptor antagonists like zibotentan, rhodiola rosea is a Russian herb. The trials are on. Stem cells and coronary sinus reducer, which is an hourglass gadget which can be put in the coronary sinus and improve the coronary arterial blood flow. EECP has also been tried. The trials are still on and nothing conclusive. Cardiovascular treatments in INOCA, less than half the patients with INOCA are treated properly. Important thing is you have to reduce the stress. You have to reduce the recreational
Meenakshi,
uses of
we are running out of time.
cocaine.
Can you go to the conclusion slide, please?
To conclude, up to 50% of patients undergoing elective CAG for chest pain do not have obstructive CAD. INOCA remains a diagnostic and therapeutic challenge. These patients are often discharged with the diagnosis of non-cardiac chest pain, yet many could have an ischemic basis for their symptoms. They should be followed up with intravascular imaging, IDP assessment of coronary physiology for macro and microvascular dysfunction. The goals of therapy are amelioration of symptoms and reduction in the CV risk. INOCA patients, if left untreated, have elevated MACE, reduced quality of life, and frequent hospitalization, and hence have to be identified and treated. Thank you.